Good evening, everybody. Apologies for interrupting this wonderful meal that's been prepared by the staff at Liwa Restaurant, but if we could just give them a round of applause. I am Jaleese Thomas. I'm the Director of Research Health Equity for the Clinical and Translational Science Collaborative of Northern Ohio. Thank you.
Hi, everybody. I'm Zena Hempstead, Manager of Health Equity Research in CTSC.
We'd like to extend gratitude to the Planning Committee, whose lived experiences, work experiences, and training and education help inform the third annual Health Equity Challenge Series. Fan Glavin, she is in the room right here, and it's just, yes, please. It is incredibly wonderful to co-create, collaborate, and fill spaces like this with wonderful people like you. We'd also like to acknowledge our Executive Director, Shannon Switkowski, and Director of Strategic Partnerships and Research Development, Laura Parent. All right, so please continue eating, but we will play the clip since we're running a little bit behind schedule, but we have a fantastic panel. I mean, just the best of the best here for our Asian American Pacific Islander community, research, and integrative health, so you are in for a treat.
You got it? Yeah. Got it.
Please. Yeah. No. Thank you.
Of the Asian and Pacific Islander National Cancer Survivors Network.
Upper quadrant of my right breast. And I decided that I ought to get this thing checked out.
One story that we often retell at the Asian and Pacific Islander American Health Forum is the story of Susan Shinagawa, who is the founder of the Asian and Pacific Islander National Cancer Survivors Network. It took her repeated doctor's visits before she ultimately was told that she had breast cancer. And the reason for that is one of her doctor's original responses was that, Asian women don't get breast cancer. And that was kind of based on this understanding that Asians as a whole are healthier than other communities.
When people talk about minorities, they frequently mean Black, Latino, Latinx, Native American, and then they don't really include Asian Americans into that. We have internalized this idea that Asian Americans are sort of the mono minority and therefore don't suffer from racism, don't suffer from systemic injustice, and therefore are no longer counted as a minority in some ways. And I can tell you from personal experience, we certainly do face racism. We certainly do face many of those barriers.
Asian Americans are now the fastest growing demographic in the United States, growing 72% from 2000 to 2015, mostly due to immigration. Despite this,
A recent review, for example, showed that clinical research by the NIH,
that's the National Institute of Health,
focused on Asian American and Native Hawaiian Pacific Islander participants, accounted for just 0.17% of the NIH budget over the past 25 years. And so there has not been a prioritization of research dollars focused specifically on the Asian American community.
So why is research so lacking? You might have heard the term model minority. There's a common perception that Asian Americans are doing well compared to other ethnic groups.
So the model minority myth in the context of healthcare is this idea that when we look at Asians as a whole, they're doing well in the context of overall health. They're not necessarily impacted by diseases the way that other racial and ethnic communities are.
To debunk this myth, we need to take a step back and ask, what do we mean when we say Asian? One of the issues with the racial and ethnic categories we use is that they combine very different cultures under one name.
Asian American is actually probably the largest diaspora of people that exist. If you can imagine, Asia is actually the largest continent in the world, and it has the most people in the world. And so it's a bit arbitrary, really, when you sort of decide, like, okay, so this whole continent is going to be one group of people. We don't ever look at health statistics and say, how are North Americans in general doing? And in fact, most of us don't identify as North American. Many of us identify as American or Mexican or Canadian. The disaggregation of Asian American data is probably one of the most important issues for Asian American health that exists in this country.
Disaggregation is basically breaking down a large group into smaller subgroups. So for example, within the Asian American community, there's Koreans, Japanese, Indians, Pakistanis, and each of them have different social and demographic characteristics that all impact their health status.
Particularly in this country, Asian Americans have a significant, what we call a bimodal distribution, in the sense that we have a lot of folks who are sort of disadvantaged, poor, low educational status, low health literacy, but we also have a high number of Asians who have socioeconomic privilege, educational attainment.
Historically, U.S. immigration policy has created two tracks of immigration. One for the laboring class, which is allowed to enter during times of crisis or when cheap labor is needed, and refugees, many fleeing conflict in Southeast Asian countries like Vietnam, Laos, and Cambodia. And one for wealthy, educated workers for industries that demand highly skilled labor.
When we look at Seattle, I see the same pattern playing out in two distinctive areas. Colloquially, one could consider sort of the UW Asian. These are the graduate students, these are their undergraduate students, both foreign and domestic, younger, more affluent Taiwanese, Chinese folks who are going to school and have that trajectory intact. And then we kind of have South Seattle Asians who are living in South Center, Beacon Hill, Renton, things like that, that tend to be older Asian Americans, so older Chinese immigrants who didn't come from necessarily that sort of educational immigration, but through sort of the working class, laboring class.
Because of their backgrounds, these groups have very different health outcomes.
As an example, when we look at stomach cancer, for Asian Americans, the incidence is 14.5 per 100,000, compared to white men, which is 8.5. But when we look at some subgroups, for example, Korean men, it's around 38.5. When we look at liver cancer, Laotian men, the incidence is 66.1, more than 3 times greater than the incidence for Asian overall. There's actually subgroups that are worse off in their health outcomes than other minority communities, but that data is masked because we're looking at Asians as a whole.
Averaged out, the numbers have created the perception that Asian Americans are healthy overall, and that we don't need to research health interventions for them.
And so by creating such a large group of diverse people and creating an average and just looking at one number for them, it really misleads us in terms of what is actually happening between those individual communities.
Advocates say that lumping people under Asian American doesn't cut it anymore, at least not when it comes to healthcare and research.
The fact is that it's a growing population. There's so much diversity in the population that rapid growth is really impacting how our communities are receiving healthcare and how the healthcare system needs to adapt.
I come from Cambodia, Phnom Penh. When I was 28 years old, I left my country. I came to the United States in 1987. I come to Seattle, and I didn't speak any English at all at that time. I had depression all the time. Every time I saw people, I just cry. Because you didn't speak the language, it's so hard. You cannot tell what you feel and what you need. And when your kid's sick, you don't know how to ask for help.
Yvonne Ung is an interpreter at a health clinic in Seattle's Chinatown International District.
And they had their result from yesterday.
係，我哋有琴日嗰啲結果喺度㗎啦，喺我哋嘅記錄度。
She knows 5 languages and spends her days helping patients who aren't fluent in English.
I didn't see a doctor for 10 years myself. No physical checkup, nothing. Then just stay home and get sick sometimes. One day I get a kidney stone. My goodness, so painful. I didn't want to go because I don't know how to tell them and how they understand me.
Every day, patients in Washington state rely on interpreters like Yvonne to communicate with their doctors, pharmacists, dentists, and other providers. These language access services are in fact required by both federal and state law.
People are supposed to be able to receive healthcare services in the language that they prefer or speak best. What's actually happening is that law isn't really very strongly enforced, and so there's a lot of variation in what patients experience.
In Washington state, 1 in 7 residents is foreign born, either an immigrant or a refugee. About 20% of the population speaks a language other than English at home. According to the latest figures, around 9% of Washingtonians are reported to have limited English proficiency. That's over 500,000 people, though experts say it's likely an undercount. This LEP population has grown substantially in the past few decades at one of the fastest rates in the country. The most commonly spoken languages in Washington are Spanish by a long shot, followed by Vietnamese, Russian, Ukrainian, Tagalog, Korean, Somali, and over 200 more languages. So how are these folks accessing healthcare services? Asifa Tasema is from Ethiopia.
My first language is Tigrinya. I speak to Amharic.
Hello. How are you? Good. How are you? Good. Feeling somewhere fancy?
Happy to help.
Yes.
Happy to
Always.
see you.
Happy to see you.
I'm going to my doctor.
Okay. Have fun.
Thank you.
Okay. Bye-bye.
He says he could get by without an interpreter, but it's better to have one.
There are technical words, medical words that I don't understand. So, to make sure, it is good to have a translator.
Anything else bothering you that I didn't ask you about?
In a healthcare setting, miscommunication can have serious and costly repercussions. Patients who aren't fluent in English might avoid going to the doctor, miss appointments, or leave an appointment missing crucial information, like how to prepare for a surgery or how to take medication.
When health services aren't provided in the right language, it leads to more errors, more time getting people well.
Over time, these language barriers lead to longer hospital stays, more readmissions, and worse health outcomes.
It ends up costing society more because people show up in the emergency room at late stages of disease because they haven't been able to get the preventive care that they needed.
Tasema is in luck here. Experts say that large systems such as Harborview and the University of Washington Medical Center offer robust language services of all kinds. These include in-person interpreters, teleinterpretation over the phone, as well as through video remote service and written translations. But at some clinics and offices, it's another story.
We hear about the lack of interpreters or patients being asked to bring their own interpreter or being turned away from care because they need language assistance. All those things are illegal, but they happen all the time.
Many places just aren't able to provide services in all the languages that their patients need. And many don't know their own rights, and so they don't know to ask for those kinds of services. And there's a lot of variation in quality even when they get them.
Take Medicaid patients in Washington, who put in over 320,000 requests for interpreter services in 2020. The state aims to fill 90% of interpreter requests for these 7 most requested languages. For languages that are less frequently spoken but still in high demand, it aims to fill 70% of requests. But it's still falling short in many places, leading patients to fall through the cracks. Many patients don't know they have the right to translated documents or an interpreter, or they're afraid they'll have to pay for interpretation, so they don't request it. It's up to the individual to file a complaint, but experts say that's not likely to happen, given how disenfranchised these patients feel in the current political climate.
We have a very diverse population now and a big growth of people who need language assistance. We have, particularly in Western Washington, people from all over the world, but we have fallen behind in actually having communication services be available for everyone who needs them when they need them. There can't be diagnosis and treatment without communication.
This series is made.
All right, so the 2 segments that you just saw were hidden barriers, healthcare's hidden minority, as well as lost in translation. So we hope that you will kind of reflect on those short pieces and have some really great questions for our panelists. But without further ado, we'd like to welcome our moderator, Rothy Rim. She's a research program manager at Cleveland Clinic. And the rest of our panelists, we have Dr. David Vincent from UH Conner Whole Health, Dr. Jacob Hill from Cleveland Clinic Center for Wellness Research and Training, Dr. Fan Glavin from Case Western Reserve University, Feiran from Asiatown and Midtown Cleveland, and Dr. Stephanie Dooley from Neighborhood Family Practice. If you'll join us at the front, we'll begin.
Go ahead.
Well, thank you.
You need one more chair?
Well, I just want to thank everyone. Hi, everyone. I just wanted to take a moment to thank everyone that took time out of their evening to come and join us for this event. So I hope you had a few minutes to really think about it. And I just wanted to open it up to the floor to see what stood out with those 2 videos that we just watched and your thoughts about that. Feel free to stand up.
My name is Sissy Watkins. I work with the Race and Race program, so working alongside researchers and doing community work. My thoughts were, I actually come from the Pacific Northwest. I grew up in Oregon and I spent some time in Seattle as well. And the language barriers that come
from in the medical standpoint are a very, very big deal. So a lot of our parents and our grandparents were all raised without health access. And so to them, you do not go to the doctors until it is an ER emergency. And so a lot of them do not get preventive care. And they talked about that in the first clip. And so as a community health worker, I see that a lot. We're doing the preventive care, giving the education to let them know that those services are available is really important. And I also feel like there is not enough education in advocacy when it comes to patients feeling like they have a right to say something. There is a large power dynamic when it comes to receiving medical or educational support. I would say on the other side of it that they didn't touch base is there's also a lot of bias within how people view the education that someone may get if they are a part of Asian heritage. So like if you are someone who struggles with and needs an IEP or something like that, and you're seen as, well, you should be smart, they're more likely to fall through the cracks as well. So I see it on the education standpoint and on the medical standpoint as well. So that was what my thoughts were.
My name's Mary, and I just was surprised. I didn't really even think about the large geographic area for the Asian population and how different we all are. As we look around the room, we can see the differences, and there are big differences, as I saw in the percentages of the different conditions for everyone.
Thank you. And
my name is JP, and something that the piece about the translation really resonated with my experience. I spent a year of AmeriCorps service working here in Cleveland in refugee resettlement, and my job specifically was healthcare navigation. So I actually spent a year going to just about every hospital in Northeast Ohio, bringing people who don't speak English and helping them just access the healthcare system. And oftentimes people would look at me like I was the interpreter, and I was literally just there to help them navigate, and oftentimes found myself in a position where I was educating hospital staff on, yes, you do have access to a language line. Yes, you do have interpretation. Actually, it's legally required, so I'm sure you are in compliance with those legal requirements. So I would just say that is not just a Pacific Northwest challenge, but also very real here in Northeast Ohio. And I would make a plea to my colleagues in healthcare institutions that we need continued and ongoing professional development about these challenges if that's not already part of your regular cycle.
any other individuals that like to speak out in regards to?
Hi everyone, my name is Hai Tong. I'm one of the medical students at Case Western with Amy and Alice. We are currently working with Dr. Glavin and Feiran on a project in terms of Asian Americans, particularly in the participation within clinical trials. And we just got approved for IRB finally, which is really nice. And we do think that the population within Cleveland, even the Asian population, is very diverse. Before I came here, I definitely didn't know much about like the different populations of Asian Americans within Cleveland, and we're trying to. I think within the video they talked about kind of like separating, having like to find the diversity within the Asian population, and we're trying to find like different groups and trying to see the difference in terms of the barriers they've been facing with participation within the clinical trials. So we're very excited to be here, and thank you for the opportunity.
Awesome.
Thank you. Thank you. Anyone else before I open it up to the panel?
Yes. Good evening. Thanks everybody for coming tonight. One of the things I think generalizing a lot of culture is the norm in the United States. We tend to make a lot of assumptions, not just in healthcare, but in society. And it's amazing to have events like this where we can kind of open our eyes to the unspoken biases that we personally hide or have seen in our careers or experiences. And so I was formerly a university professor, and we had an exchange program with the university in China, and a lot of the instructors just made, very unique generalizations about the population. But when you talk to the people, when you talk to the students, you find out there's so many unique differences in just speaking to the people. And so I think these events are great where we can open up the room, open up the conversation, and uncover some of those, kind of quote hidden barriers to even just making relationships in general, but then uncovering more of maybe some problems that are surrounding us in general. So thank you all.
Well, I'm going to add also just watching the video, the second video, just realizing how they're showing the different countries. And I love that they're educating us in it, but I did notice that they put Cambodian and Khmer in one, when it's one in the same. So even from that video itself, I'm just like, okay. So, but it's one in the same. It's not two different ethnic groups. So I just wanted to, that's what I've acknowledged or noticed in the video. But with that, I wanted to open up to Dr. Glavin. So, Dr. Glavin, the first segment of health care invisible minority defined that desegregation as breaking down or separating into component parts, such as subpopulations. You are a 2024 CTSC Ready Theme Pilot Awardee. Congratulations.
Yeah.
So, could you tell us about the work that you've been doing with AAPI Coalition with segregation, desegregating the health data in AAPI community, please?
Sure. First, thanks CTSC and give us the money. And actually, it's the first funding for AAPI community to really looking at the issues and solutions. So thank you very much, CTSC and my medical school colleague. And I think the disaggregated data and speaking the first tapes, actually we found out through our study in the local base. So you look at the population distributions in the Cuyahoga County, and which is about 3% of AAPI community, and that's underestimated, probably between 3 to 4%. And the total number probably between 35% to 35,000 to 40,000. So it's kind of a keep on growing number when all the population went down and the Asian community going up in the county level as well as the state level. And so we will first look at the data. They will take us to a total different direction. And we look at the percentage of AAPI communities in the Cuyahoga County. Guess which one is the area is the largest AAPI community population in terms of percentage of a population? Anybody want to give a guess? Pardon? No, I'm thinking about the county. There's a lot of villages and cities, and where are the highest percentage of AAPI community in terms of a Cuyahoga County? Parma? Okay. Cuyahoga. And Cuyahoga. Solon. Yeah. Well, if I tell you that's the first example, mislead us to the study. And the highest population is Pepper Pike. The next one is somebody say Solon, and then is the Beechwood, right? And it makes sense. And Middleborough Heights. And if we take that data, we say this is where the AAPI population is, we're wrong. And the highest number of AAPI community are around the Asiatown areas. And we find out some of the, we call emerging AAPI population in the west side and the Palmar area. Somebody mentioned about that. And we also have this new emerging Afghanistan and refugees populations. So I think that's kind of the first things in terms of you answer the question about if we move in the right direction by the statistics, we will miss our boat. So what we have done was the first funding from the Cuyahoga County Board of Health, which is state funding, And rather than going to the community collecting data, which our conventions do all the time, right? We went to 8 different ethnic groups and work with the leader, reach the grassroots population to make sure we get the right data. And, we don't have time to share the data, but definitely the disparities happen. Give you an example, COVID infection rate. The highest rate is Vietnamese population, which is 60%. The lowest population is the Chinese population, is 34%. So you can see the range, but you look at the hesitancy. Of course, Vietnamese have the 60% hesitancy, and that creates a high infection rate. But there's a lot of factors if you look at the disaggregated data and you find more value in terms of the reasons and how you take the intervention goes. So, and then you ask people why you don't take vaccines. And very interesting is, and that range from I don't believe, religions, various type of things, to a regulation. If you don't get vaccine, you cannot come to the United States, right? So there's a various reason when you deal with this population in terms of help to booster the vaccination. So that's a kind of example. We're doing that. And what we're going to do with that, there's a group of stakeholders put together. Of course, if you're interested, please contact me. And we're taking a system approach. We're to emerge multiple set of data. And I think the data are very fragmented. Public health collect their data, hospital have electronic medical records, and then community have its own data. Then we have a CDC, have the huge data. So there's a group working together to integrate all the data and try to find the best way to standardize. You mentioned about the ethnic groups in terms of how that correlate with the outcomes, healthcare outcomes. And we just submitted a grant. We have a Cleveland Foundation population health model, epidemiology. Cleveland, the good things about Cleveland is we have so much resources. And all you have to do is just tap in.
Thank you for that. Thank you. So the next question goes to Feiran. As a community organizer for Asiatown in Midtown Cleveland, how have you seen the Asian American bimodal distribution in our community? For reference, in the first segment of the Healthcare Invisible Minority, the narrative explained that Asian Americans have both high educational attainment, wealth, and high health literacy, contrast with the low economic resources and educational status health literacy.
Yeah, I guess everyone already see what shows in this documentary. And I want you to think about the first question I have is, who is the first Asian in your life you are familiar with? Is that your colleague cohorts or friends from your schools or just some random stuffs from Chinese restaurants? And maybe the answer can be various, but it's exactly the answer for why people saw is the bimodal distribution. Because for Asiatown residents, we are already in Asiatown now, you can see most of the Asian population, they are started their U.S. life, immigrant life in Cleveland, start with their business. So most of the residents, they come to U.S. as a business owner or come with their business owner family members. And do they have higher level education? Do they are familiar with the healthcare system or health literacy? Or do they have accessible language access to every healthcare they want to have? Maybe not. This is why, as a community organizer, we try to help to get most of the accessible resources. And this is why my job was existed right now. Because for most of the Asiatown residents, if they have kids, they will stay here with their business. And then when the kids getting older, go to high school, they have most of potential to move to Solon because Solon have a very good public high school. And that is also happened for a lot of the family in Asiatown. So why people always see the high education and the economic success people Asian as a very modern minority Asian, but for most of the Asian who are not be seen is actually the majority of the Asian who live in Asiatown. So I guess that is my answer for this question. But also like for most of community organizer, we really want to help them to get enough access, not just to stop them by language barrier. I actually have a lot of real story. One of the stories from our last research with Dr. Glavin is one of the Indian lady just pregnant during pandemic. And for Indian population, she shared that it's easy to get diabetes when they get pregnant, but diabetes for U.S. healthcare system, maybe it's not the health provider's priority to test. So that's why she got actually a very bad side effect because of pandemic, because of the lack of resources and the lack of communication, and getting this pregnancy process getting worse. And another is we have a senior apartment in East 13th Street, and most of the seniors are over 75 years old and have very limited language English level because they are come with their children. So even they got green card or even they are already citizens, but they still cannot get into hospital very easily. So I guess that's a lot of barriers we can see. It's not invisible by community organizers level. So, yes, thank you.
No, thank you. I know I have an aunt, and she's been here forever, and she still can't read. So
Yeah.
I totally understand. And but this next question is to Dr. Vincent. Will you please define integrative health for us and how UH Cooper as a whole provide culturally sensitive care?
So integrative health, over the years, has been a variety of names, right? So when I started my career, we were alternative, became complementary, and slowly turned into this integrative medicine. So in many ways, the work we do was considered outside of the health system, so can relate in many ways to the conversation we're having. So when we think about integrative care, we think about the things that are not typically taught in medical school. So think acupuncture and chiropractic and yoga therapy and art and music therapy, mindfulness practices, stress management, that type of stuff. That all falls into, at university hospitals, into the realm of integrative health. And we would address inequities through what I've been really working on in my career is access. So why bring integrative or alternative medicine to health systems and larger systems where we could operate outside of that quite easily and be successfully, and it's really about access. So we try to look for those barriers. How do we change the way that people can access and provide, allow us to provide care to all people from all social economic classes, from all races, from all areas. And I think the main word that we would use is do that with cultural humility, understanding that we may not know. Particularly when we talk about integrative health, a lot of those things that we do are traditional to a family. It wouldn't be considered alternative at all. And understanding that within medicine, that a family is already practicing many of these things, and being able to understand that, have the humility to say that you may not know what that culture is like, what those practices are like, and being involved at that level. You know, in whole health, which is what we call ourselves, it's really patient-centric. We really ask the question, what matters most to you today? And what matters most to you, to your family and your community? which is the outward part of the whole health model, is you can't take care of the person without taking care of the community. So that's how we approach care.
That's fantastic. Thank you. Dr. Hill, as a member of the Cleveland Clinic Center for Wellness and Research training, can you share how your research of non-pharmacological interventions for mental and physical well-being intersects with Eastern medicine traditions?
Yeah, sure. So, can you guys everyone hear me? No? There we go. It's got to get pretty close there.
Yeah, I think you
We do. Sure. I want to kind of expand on what was defined with integrative medicine and then how that plays into the research that we do at the Cleveland Clinic within wellness and preventive medicine. A lot of what we do is derived from integrative medicine, but integrative medicine, from my perspective, really is a conglomeration of traditional practices put together and kind of relabeled in a sense. Integrative medicine is not necessarily a brand new thing. There's, under this broad umbrella is acupuncture, is yoga, is mindfulness. Where are these coming from? Many of them are from Asian traditional medicine practices, right? And so there's one issue within integrative medicine, and that is it's been brought to the United States and put into research and sometimes repackaged as something new and fancy. And that's appropriation, right? That's appropriation of traditional practices. And that is something that is first and foremost really important to address when you're a clinician or a researcher and you're presenting something to a patient or participant and it's something new and fancy. And to acknowledge that I didn't create the things that I'm researching. These have already been created 2,000, 3,000 years ago that we're just now researching maybe in a different population or in a different way. So that's first. What I wanted to kind of address as far as how we approach integrative medicine research within the center that we do research in. Now, specific to Eastern medicine traditions, we're fairly heavy on mindfulness research within our center. And mindfulness is, of course, derived really the concept from Buddhism. So a lot of what we do is to take something that came from this cultural practice and not assume that it fits everyone's cultures or beliefs or ways of viewing depression, anxiety, or life and how that may help them. So what we do is a lot of times talk to the community, talk to the participant, have them be really vitally involved with our studies to help lead us and guide us in developing research studies that is applicable and relevant to them, so that something like mindfulness can help them in the things that specifically stress them or make them anxious and for that population. So mindfulness is really where we're kind of intersecting with Eastern traditional medicines in our research. So
thank you. So my next question goes to Dr. Dooley. Some subgroups are off or worse off, for instance, stomach or liver cancer, and health-wise within the Asian Pacific island community. How does neighborhood family practice help address differences in health outcomes for various subgroups from both a treatment and language access perspective?
Yeah, so I'm a family medicine physician at Neighborhood Family Practice. At Neighborhood Family Practice is an FQHC on the west side of Cleveland predominantly. So we serve primary care, but we also welcome a bunch of refugee and newcomers to our locations. So with that, I have kind of a flow of how Neighborhood Family Practice goes about this kind of care. The first thing, which I think is most important and identified in the videos, is getting culturally appropriate language interpretation. And so identifying, too, that there are different dialects within languages as well. And so asking patients in front of you if they're understanding the conversation, first off. Patients who arrive, too, we want to talk about where they were born, migration as well, so where they have been, and how they arrived to the United States, which primary care integrative health does an amazing job at, collecting that social history. Many who come to our location also get laboratory screenings. So the important thing to note, the cancers that were identified, both stomach and liver, are often driven by factors in the environment as well as things that may have happened during birth. So hepatitis is a big one, and then
Helicobacter pylori, so H. pylori, how most people hear it in the community. So knowing our patients may be at risk for those things. It's hard because, as identified as well, there's not a lot of research in this and which populations may be more at risk. So our practitioners are great and stay very informed in terms of a patient presenting potentially with just reflux might be more than that. So screening for those things and getting treatment for something that we can prevent, such as liver cancer and stomach cancer specifically. Additionally, we work really hard to limit any stigma that goes around those diseases. Sometimes hearing that can be very difficult, and some patients will even know embarrassment. So we talk about transmission, that it's safe to hug your children, and all those things in those visits. The next steps are the action parts. So assuring follow-ups with our partners, Cleveland Clinic, University Hospitals, Metro Health. We have good relationships with their providers there. In addition to offering other ways of healing, so integrative health colleagues, that sometimes healing looks different for different cultures, and including that in their treatment process.
Thank you. So back to Dr. Vincent, can you share a bit about your work relating to health policies around universal access to and coverage for licensed complementary alternative practitioners? And how that could increase access and improve health outcomes within the Asian community?
Sure, it's been a bit of my life's work. I do chair the policy committee and the academic consortium for integrative health and medicine. Again, I'll bring back up access. So a lot of the work that we do is try to influence through research, and I'll add at university hospitals at Connor Integrative Health, we've been given $2 million to study the efficacy of the work that we do in order to change policy. That was written to specifically do that. It was a private funder, actually, who was determined to change policy that would allow for increased access through insurance payers and government changes. And a lot of the work that we're doing is to push that work and influence those people in government. We also try to get the people that are involved at Connor at a high level, involved with their national societies and their state societies, to continue to improve access. At the academic consortium, which I think is probably picking that up from the question, we partner with Whole Health Initiative. We partner with other funders to try to influence, again, at the national level, in that case, how healthcare policy can be driven to provide access. Now, in Ohio, we've made headway. So Medicare and Medicaid primarily has a very robust acupuncture benefit, which didn't happen a few years back. And that was a lot of the work of my colleagues that were able to initially get in there through pain, but ultimately open the gates so that people on Medicaid can have acupuncture for a variety of conditions, and it's quite robust. And chiropractic as well, and we'll continue to move that dial. I've been at this work for 30, 40, some years, and we can see that it's changed pretty dramatically over time, but we do have to look back and really reflect sometimes to see that work has been worth it. But I think providing access, providing availability, I jotted down some things. So integrative health typically has been white, affluent women, right? So even in our clinic, if I look at last year's data, we were 75% female. We were 78% white. And when we look at sort of our Asian Pacific population, we were about 2%. So we're off a couple percent is our population in Cuyahoga County, but clearly off the mark when we look at our total community. So providing access, providing means, looking at ways that we can bring this great care, this necessary care to our community is important. I'm going to add something. When we looked at the barriers, like if you're in an office or you have anything to do with a medical office, please make sure that you know how to access interpreting services in a small office, even an office of our size, in 4 locations. We find it challenging sometimes, but you do have to take that extra step to make sure you know whether it's an app or whatever it is that you have access to. It's such an important piece in that communication that can be such a barrier to health. And so specifically for the Asian Pacific population, I would say that we're not reaching out to that community particularly as much as the whole of Cuyahoga County, but it really is driving all those same things. How do we provide access to the care that we deliver with people with a wide variety of community, a wide variety of income disparities, transportation disparities, all those things. How can we do that? And that's what I do and look at every day to try to figure out how that can happen. And through our partnerships with Selena, who's here, and other pieces of it in our wellness centers and things like that. So.
Thank you. No, I think that's very important, especially getting coverage and working with insurance. So, yeah.
I want to kind of jump in, just mention a couple of things. I think when we went to the AAPI community on the grassroots population, I think one of the message we received, which is we use that for us to follow the work, is AAPI communities think they are very small. Even the largest communities in Asian and India, which is the largest community in Cuyahoga County, second is the Chinese populations. So one of the suggestions from all 19 people, leaders, is to create the AAPI health coalitions. That means we are very small and we all have limited resources. So we don't have a lot of expertise in this area, and we should work together. And so we took that concept. This is a kind of a problem not only just for AAPI communities, but also for a lot of people serving the AAPI community, is where to find them. And they're all over the place. And if you found them, you found grant group. So the AAPI Health Coalition has been driven the directions we're moving to, based on the data we collected from the community. So I want to introduce Commissioner Francis Mill, who's sitting in the back, and from the city. The reason I want to mention is the linguistic issues, the language issues, the interpretation issues, and it's just part of the problems. If you don't have a navigation systems, and you cannot, you can have a best translated information you can have, it's not going to help with access. So we got the grant from City of Cleveland, and actually we are in the process to plan a single access center for all the AAPI communities. So I just want to kind of address that issue. So I think that's probably Dr. Vincent talked about, is a lot of language and culture issues. So hopefully we are able to finish. And GIP from Case School of Social Work, and is going to work on this project, and we're going to have the plan by the end of the year, I hope, and for implementation. So hopefully get some funding to do that. Okay.
Thank you, Dr. Glavin. Dr. Hill, so it looks you're a 2024 CTSC Ready Theme Pilot Awardee, so congratulations to that.
Thank you.
Are there parallels from your project that could apply to the Asian American community for future research study?
Yeah, I think I believe so, yes. I mean, first, I just wanted to acknowledge, like, as a researcher, there's just not enough funders who are prioritizing health equity and asking for ways to incorporate underrepresented populations in research. And just want to shout out the CTSC for being there, and Jaleesa and her team, and supporting these efforts, because the funders drive a lot of what researchers do. We need the money to do the studies, and if funders are not prioritizing this, it's not getting built in to studies. So I just want to acknowledge that first. As far as the study, what we are doing with this study is we're looking at an abbreviated mindfulness-based cognitive therapy intervention for an older Black breast cancer survivor population. And now, while the results won't translate directly, obviously, to an AAPI population really in any way, it's the process of how we're doing the study that we are trying to create a method for future studies to move forward to really get underrepresented populations into integrative medicine research. And there's a few examples of how we're doing that. One is that we establish community advisory boards with individuals from the community who meet with the research team directly and talk to us about how should we be designing our studies, what should recruitment methods look like, what are retention methods we can use, how do we advertise, what pictures do you want to see on the advertisements, what language do you want to see within the questions that we're asking. It really drives a lot of what the research, like we know how to do the research, we don't know the culture for the population we're working with. So they're the experts in that while we work together in collaboration to design a study. So this study has a community advisory board of older Black breast cancer survivors. We're doing focus groups up front where we bring this intervention, the basic concept of it, we describe it to our focus groups and say, all right, tell us how this may or may not work for you. What are things that we don't see that might be barriers to participating in this? What are the stressors that you specifically as an older Black breast cancer survivor experience that we can incorporate and talk about in this mindfulness intervention so it's addressed and is relevant for you? Because what's relevant for someone else may not be relevant for you. So while we have data saying that mindfulness-based cognitive therapy works in a white population, we can't say that works for everybody. So, especially something like a complex behavioral health intervention where you're talking about very personal things in a group, things that make you depressed or stressed or anxious. There's obviously a lot of cultural aspects that need to be considered there. So doing these upfront focus groups. And then one other thing about this funding mechanism that was emphasized through CTSC, which I absolutely love, is the initiative to remove barriers to participation in clinical trials. So anybody who knows about research knows that there's obviously there's a history of taking advantage of disenfranchised and marginalized populations in research. So there's a lack of trust. Absolutely. So having this community advisory board, having these focus groups up front is a way for the community to talk to us as researchers to say, this is how you can help build trust. This is how you can help reduce barriers for our community to participate in your clinical trials. So it's the model of that, not necessarily the results of this specific study, but the model of that we want to see, is this going to work to, get people engaged in the intervention and in the study and keep people in it and hopefully have positive health outcomes in the long run. But that model can be then translated into other populations, AAPI, Hispanic, whatever it might be, is to really just have the voice of the participants speak to the research team and help from the start to finish develop and almost run the study in tandem. Yeah.
Thank you for your insight on that. And Feiran, last question goes to you. What role would community development corporations like Midtown play to help facilitate better access and quality of care and inclusion in the Asian Americans?
I'm very appreciate you asking this question because for most of people maybe don't know we are CDC is not the Center of Disease Control, but we are Community Development Corporation. If you know downtown and University Circle, yes, Midtown is a small space between those different cities. Yeah, so what we are doing is we are the basic community-based organization to help services community. So actually for Asiatown residents, Midtown residents, we are share the first-hand information with each other, especially during pandemic, like people who don't know how to access for all of the information, where to get vaccine, where to go to clinic, where I can get the kit, and they will reach out for us to say, and we will share all the information, whether it's translated or the original official information. It's our job to share that. So basically the first thing we can do is as a bridge to provide services between residents and healthcare provider. And second is about we also have a lot of community events running on. So based on Asiatown, we are very focused on the Asian immigrants' needs. The first one we have is an English adult literacy session is for senior who want to learn English. And the second one is a dance group. The third one, surprise, we have a mathematics class. I know that's very stereotype, but this is what we have. It's all about residents' well-being. So also the same is we want to provide more like healthcare literacy for residents, for them to know, like when you go to hospital, what's the first question you need to answer, and what's will the health provider will ask you, and don't be nervous when you are stay alone in the clinic because the health provider will reach out for you later. Like there are a lot of barrier can make people feel nervous. Maybe this is a lot of barrier for feel unsafety, but we can teach them or like give them at least more information based on CDC's program to let them know you can feel comfortable, feel safe to go to the hospital whenever you want. And another thing is about we also have CDC have a bunch of network for Asiatown residents. We have reached out a lot with Asian Services in Action. They helped us a lot based on legacy issue, the healthcare issue, and the language access issue. So and also they have the ICHC International Community Health Center. They're also doing a lot of help for us. So if you don't know anything about how to accessible in Asian population, or like how to having a research in Asian community, so you definitely can reach out to your targeted CDC's Community Development Corporation to help you engage and get more information from this community. Also, based on our responsibility, we also want to create a safety, a clean, and more healthier community for everyone in Midtown and in whole Cleveland. That's not just for them to access for healthcare, but also like a more clean road, clean street, like make people don't falling during the winter, and more accessible information and the transportation. That's all can make the community residents feel better and live better. So that is how Community Development Corporation can be the first hands you can reach out if you want to have a research or just want to serve and reach out for Asian population.
Thank you. And Dr. Glavin, this is the last one, I promise. What does the inclusion and research and health equity look like for Asian Americans in the next 5 to 10 years?
I don't know if you have time to listen about that, but I think everybody wants to go home right now. So I just go very quickly. In the next 5-10 years, what our vision is to create the Asian Health Coalitions. So there's a platform people can go there for information, outreach to the community, receive technical support, and also help to promote AAPI in terms of advocacy. I think that's the first things, and we like to see. The second one is aggregate data and disaggregate data for the AAPI communities, which is, I think, you all need. If you don't have data, you don't have anything to monitor, you don't have any resource to give, and you don't know if you're doing anything in the right way. So I think the AAPI data is going to be the second issues which we're going to collaborate with the epidemiology department from Case Western and Cleveland Clinics on health population health, and Metro Health on the electronic medical records, and as well as the national organizations like AAPI in California. So hopefully we are going to do some pioneer work right in our backyard in Cuyahoga County to become the model in terms of the AAPI community. The third one is, what we talked about, City of Cleveland already putting the initial funding is we want to create this one single access, single point of access. So people don't, in the AAPI community, do not have to go to 10 different hospitals, 5 different community health agencies, and to get care. And they are able to go through this center in terms of translations, interpretations, and navigations, and to actually have access of the quality care. The last one, actually, we just talked about. We interviewed a physician from Cleveland Clinics as well as Metro Health, and the big issue is there is a lack of standardized practice guideline for the physicians to treat this type of patients. And we talk about the cancer, but we also have other issues such as depression, substance abuse. And so one of the things that I think we've been talking to some of the physician group is to try to, you are involved, to create the best practice guidelines and to treat the AAPI community in the cultural, competent way. So if we can kind of reach that in the next 5 to 10 years, and I think we have accomplished a lot. And but one of the very important things, the partnership. We cannot do this without you. So please join us and co-design and what we plan to do and make sure we all work together on this. Good.
Well, I just wanted to take time to thank the panelists for your discussion and your insight and expertise in this very important discussion. And then just, I know we're running out of time, but I wanted to just take one more moment to open up to the floor. If you have any other questions, concerns, please raise your hand and we'll bring the mic to you.
Okay, hello, my name is Elton. I just arrived Cleveland for 3 weeks ago. I'm Case Western University student, and forgive me, my English is not good yet. But I just wonder that that many data you guys study about is the Asian American. So I'm Asian, but I'm not an Asian American because I'm a graduate student. So I think the Asian who live in the U.S. now, like H1, like F1 visa or J1 visa, they would give experience more barrier about language or healthcare thing. Like if I meet Korean American in here, I feel very gap because they are very good at English or they are very well used in this American society. But like international student or who temporarily live in this United States, I think they would experience more that kind of language barrier, health barrier kind of thing. So I just wonder that kind of Asian American data also included the kind of Asian who live in the United States temporarily or just excluded in the data. Yeah, I just wonder about that. Yeah.
I can answer a little bit because I'm also Asian and I'm an arrangement from China. And I just have an ACL knee surgery last year, which is a lot of barrier for me myself. Even I already know a lot of community resources, and I think I'm good at English a little bit. But still, when the doctor asked me, so you got ACL completely tiered, I was like, what is ACL? Sorry. So I even don't know where I'm hurt, but I know something hurt. So it's still, I think for like Cleveland Clinic and the University Hospital, they're still open for whoever you are. If you're whoever you are a human being first. So they will give care for you as a human being first. And then maybe something different is about your insurance company and based on your immigrant status. But still, I would say still some barriers based on if you have money or not. Yeah, that's a lot of issues need to be think about.
We did a data analysis in Korea populations, and what we did, and the first time we totally, probably is our mistake, and we have all the respondents are over 65 years old. So the senior communities are very powerful in the Korea community, right? You know, and they are eating together, they have occasion together, they have culture activity together, they're very, very cohesive. Compared to the younger population, which is not very cohesive at all. So we have to go in and take a second survey to understand the different issues. And the issues are very different. For the senior population, because they are older, they're looking for adult daycare centers and community type of services, and they don't want to go to the nursing home because they couldn't speak English, they don't like the food, and they'd rather to stay in the community. So it's very important for us to design the service is a community-based, home-based, and culturally based services, which is I think we're kind of talking to them. The younger population is very different. They're looking for lifestyle changes. You know, they want to be on the board of community organizations. They like to have a good park going around. They like to have a social activities. All younger people get together. So they're very different issues, even they are in the same group. So we have to address that issues. On the other hand, you think the younger population do not have any healthcare issues? We're wrong. And they're very insecure about the U.S. system. They think the U.S. system is too complicated to deal with, and plus most of the younger population have no problem in terms of language, but they have a problem in terms of system, how to navigate the system. So I don't know if you answer some of your questions. Yeah.
Yeah, just really quick from the research perspective too. It's unfortunate that. Language is an obvious barrier, and so much of research done does not set aside funds for translating materials to other languages, which is a big concern because some of the surveys that we implement in research are 50 to 100 questions long. You know, if someone understands 75% of that, but they're guessing on what it really means to answer the 25% other, you know, that is concerning. That's false data that's then misrepresenting a population that could drive healthcare down the line from the data obtained from that research. So something as simple as that, it's just like normalizing, we need to set aside funds for translating services, especially depending on which populations you're going for, obviously, and trying to include. But something as simple as that is it's unfortunately rare to see a lot of translated services within research. Yeah. I think it's more common in clinical practice, but in research, it still needs to come a long way. Yeah.
Any other questions?
If we could maintain your attention for 5 more minutes, we'd like to share an upcoming funding opportunity. But first, thank you again to our wonderful moderator and panelists.
Thank you. Thank you. So grateful for the invite.
And Dr. Santosh Rao.
Thank you. I get the last portion here, and probably like all of you, have a bit of food coma. While she's loading the slides, first of all, thank you for inviting me here. I think it's really important for our communities to connect. I mean, I'm Indian American, and I think we have a lot in common. I moved here from Scottsdale 2 years ago, and my one of my sons, his best friend is Vietnamese, and they had this whole argument about whether we're Asian. And his Vietnamese friend said we're not, and then my son said, well, India's in Asia, right? And this was a big thing, and I said, yeah, you're Asian American. So I'm just gonna talk about our integrative voucher or program that they're initiating. So the aim of this pilot is to support the National Center for Complementary and Integrative Health's plan. So it's NCCIH. So that used to be NCAM and others at the NIH. Their plan is to focus on whole person health using new research strategies and ideas. And these are the kind of studies that they want to espouse. So studies that include diet, nutritional supplements, physical activity, sleep, stress, and environment, and those effects on various outcomes such as quality of life, with a special focus on equity across patient populations. So these are the three aims of the pilot that the CTSC is supporting. One is models that address predictive biomarkers for disease risk in multiple organ domains. Number two is how the translational science model catalyzes solutions across institutional and community barriers. And number three is how integrative approaches reduce burdens on healthcare systems and improve outcomes over the lifespan. Okay. And the priority is going to be given to projects addressing equity in historically excluded and underserved communities and special populations, with intersectional emphasis on race and ethnicity, with some of the examples given, sex and gender, rural communities, older adults, and people with disabilities. Thank you.
All right. Thank you again, everyone, for joining us, and have a wonderful evening.
Great job. Thank you.